Okay, good evening everyone, and welcome to Take Charge for May of 2016. So tonight we've got what I think is going to be a really exciting and really good session for us. What we're going to be doing is we're going to spend a little bit of time talking about the heart, the anatomy and how it functions, but it's largely going to be a review. And I say review because we've covered this stuff not too long ago. What's going to make it special, though, is the focus isn't going to be on the anatomy. Rather, the focus is going to be on what are the tests that are available for our cardiologist, our family doctor, our surgeon to look at the various parts of the heart and make sure that they're working properly. Right? So that's what we're going to do. I'm going to kind of, I guess, do a little bit of a journey through the heart, and we're going to interrupt me with all the different tests. That is going to be our plan for today. Sounds good? Okay, so in terms of who you're going to be listening to, I think most people know me. Cardiac rehab supervisor here. I've been working here for 23 years now. Look after a lot of the patients. My degree is from U of T, physical and health education, and I'm officially now a registered kinesiologist, so that's me. The other staff, the other speakers that you have are all registered technicians. Registered cardiac technologists, okay? So we're going to be listening to them as well. Okay, so here we go. The heart is a muscular organ, all right? It's about the size of your fists. Sits here in the center of the chest, and it leans maybe a little bit to the left. Everyone thinks the heart's on the left side of the chest. It's not. It's in the middle. It just leans a little bit to the left, all right? That muscular organ is made up of 4 chambers. There's 2 chambers in the top part of the heart. They're called the atria. There's 2 chambers in the bottom of the heart, the pumping chambers. They're called the ventricles. The right side of the heart we call the right, and the left side we call the left. Very good. Excellent. Excellent. I'm glad you guys got that one. Okay. So blood comes into the hearts from the right side of the body. Right? And the blood that's coming into the right side of the heart from the body, is generally deoxygenated blood. Right? Every cell in our body requires a constant supply of oxygen-rich blood, and that's really what our heart's job is, to make sure that supply is met. So the oxygen that's been used up, the deoxygenated blood comes into the right side of the heart, comes into the right atrium, goes from the right atrium to the right ventricle. From the right ventricle, it gets pushed out to the lungs. Right? While there, it gets rid of carbon dioxide, which is a waste gas. It picks up oxygen, and then that oxygenated blood now comes back to the left atrium, goes to the left ventricle, and the left ventricle pumps it out through the aorta to all the cells in our body. Out to the tips of my fingers, out to my toes. The left ventricle is the pumping chamber of the heart. Now, it's very, very important that this flow of blood always goes down this pathway. Right? You don't want blood going back and forth, mixing with deoxygenated and oxygenated blood. That's not ideal. It needs to be nice and steady. So to make sure that happens, we've got doors or valves between all those 4 different chambers of the heart. And you can see we've got them all labeled here: the tricuspid valve, the pulmonary valve, mitral and aortic. Right? And they're all between the different chambers, and they've got one very simple job. And that's just to make sure the blood always flows in the right direction. Now, I always look at valves in a heart the same way as doors function in a house. You got a brand new house. Those doors are in the frames. They're nice and square. They open and close. They're beautiful. But as that house starts to age and it starts to settle and shift a little bit, those doors don't open and close quite as nicely. Same thing happens with the valves. Right? As we get older, those valves don't work as well, and sometimes they do allow a little bit of the blood to go back and forth. And sometimes you hear your cardiologist talk about regurgitation. Does that sound familiar? So regurgitation means your valve's not opening and closing as well as it's supposed to, and you get a little bit of backflow. You can have mild amounts, moderate amounts, severe amounts. All right? But if you're a cardiologist, we can't just go and, oh, you're a little short of breath. We want to be able to take a closer look at your valves. What kind of tests can we do to make sure that your valves are working properly? And probably the most common way that your cardiologist will do that is via something that's called an echocardiogram. All right, so what is an echocardiogram? Many people are familiar with echocardiograms because that's what we use on pregnant women. All right, you get that little wand, you put a little bit of gel on there, and you put it over the tummy, and what it does is it generates sound waves. Those sound waves come off of that wand, or transducer is the official word for it, bounces off the various structures, come back to the transducer where it's received, and in you get this nice picture. Right? That's generally how an echocardiogram works. You look at movement and structural things of the hearts. There's different ways that we can do that, or different types of echocardiograms. So a transthoracic echocardiogram is the one where they take the transducer and they just push it over your chest. How many people have had that? Yeah, a lot of people, all right? So they do that, and that lets us take a look at, are the valves opening and closing properly? Is any of the blood flowing back and forth? That works quite well. But as you can imagine, we're going through ribs and all this other tissue as well. So sometimes if we want to get a closer look, we can get the probe closer to the heart by swallowing it. Eek, gross, right? That's the second one, this transesophageal echo. What they do is they take this transducer, which is an awful lot smaller than the other one they use, and they just put it down your throat. And that can get it right beside the heart, and that can give us a much more accurate and clear picture of the various structures of the heart. So that's a second type of echo that we do. And then there's also a Doppler echocardiogram. And what this is, it's a great way to take a look at blood flow outside of the heart. So Doppler echocardiograms, probably the two most common places to see them is to look at blood flow through the neck. All right, if anyone's had a stroke or a transient ischemic attack, kind of like a mini stroke, you'll know that one of the things they take a look at is blood flow through the neck. Same thing, gel on the transducer, put that through there, or they also do it on the legs. Okay? Fourth kind is what's called a stress echocardiogram, but I'm saving that for a little bit later. We're going to talk about that in greater detail. All right? This is what the different procedures look like. So top left is just the standard echocardiogram looking through the chest wall. Not a complicated procedure, doesn't take a lot of time or prep work. The one beside that in your upper right, that's the transesophageal one where they actually go and they put the probe down your throat. And then you can see that little blue image of light taking a look at the heart that represents the sound waves. Third one is just a Doppler of the carotid arteries in the neck. And this bottom picture here on your bottom right is pretty much what the doctor's seeing. All right? I always tell people, if you want to know what an echo looks like, just pull a cable out of your TV. That's what an echo looks like. So you can see. But in this picture, which is reasonable, you can see the 4 chambers, 2 in the top and 2 in the bottom. As I said, echocardiograms are largely done to take a look in movement and structures of the hearts. All right, so any kind of problems with the valves, which is how we started with this. Congenital heart disease, so if you're born with any problems in the hearts, we can take a look at those. It's quite common. A disease of the heart muscle, which is called cardiomyopathy. The heart can start changing shape, getting a little bit larger, so we can take a look at those kind of things. If you've had a heart attack, we can pick that up as well. When you have a heart attack, part of the heart muscle dies. Dead heart muscle doesn't move. Well, if an echocardiogram is looking for movement, we could use that to pick up heart attacks. Blood flow problems as well. And then, as I said, peripheral blood flow is something that we can take a look at too. So done for a number of reasons, and these are by and large the most common ones. Largely pretty risk-free. Okay, so when they do the transesophageal or the Doppler echocardiogram, they're really just pushing up against you. So I mean, maybe if you've got sensitive skin, you might get a little bit of redness where they're pushing against you. Or if you're on blood thinners and you bruise easy, you might get a little bit of bruising. But by and large, they're largely risk-free. And even the transesophageal echo is not a huge deal. We're just putting that down in the throat. So you might get a little bit irritated in there. Some people get a bit of a cough afterwards for a few days. But by and large, they're very, very low-risk procedures. Okay? So that was a little bit about the echocardiogram. We're going to hold off on questions for the end. So just remember them for the next 45 minutes or so. Okay, so blood flows through the hearts. That's how it goes through, and that's how we check to make sure that it's flowing the right direction. So how does the heart beat? The heart beats about 100,000 times each and every single day. And for that to happen, the heart needs to contract, and for the heart to contract, we need to stimulate it electrically. The heart is a very electrical organ. Every time we stimulate the heart electrically, an impulse starts in the top part of the heart, passes over the top, gets picked up by a specialized clump of cells in the bottom part of the heart, which generates more electricity, and the bottom part of the heart contracts. Right? So this is how the electrical system works. It looks something like, see if I can make this work. Survey says.
Heart would to contract. The SA nodes. The heartbeat is controlled by the electrical system of the heart. This system is made of several parts that tell the muscle of the heart when to contract. The SA node starts the heartbeat, causing the atria, or upper chambers of the heart, to contract. The signal then travels through the AV node, the bundle of His, bundle branches, and Purkinje fibers. This causes the ventricles, the lower chambers of the heart, to contract. The flow of electrical signals produces a normal heartbeat.
Can't believe I made that work right. Okay, so the electrical system's very, very, very important. Without it, our heart's not beating. When our heart doesn't beat, we're in a whole world of trouble. So, next question would be, how does our cardiologist take a look at the electrical system of our heart to make sure it's working? So to hear about the electrical system, we're going to listen to Shital, and she'll tell us a little bit about that.
Okay, thank you, Rob. So I'm Shital. Good evening, everyone. Thank you for coming tonight. Thank you. Okay, so today I'll try my best to explain about the short history about the ECG machine. What is an ECG? How is it done? Some indications, what can be seen from your ECG, and some limitations or contraindications. Moving forward. Sure, okay. So, history of an ECG. In 1903, William Einthoven invented the ECG machine. Thank you. And he was also awarded with Nobel Prize in 1924. So just before his invention, there was no way to find any abnormal heart rhythms. The only way to see anything was by doing open heart surgery. Patients were dying without proper diagnosis and treatment back then. So I think we should be very thankful for his great invention. Up next is, what is an electrocardiogram? So some people also say ECG as well as EKG. They are both same. And ECG records the electrical activity of the heart. The ECG test is very fast, inexpensive, painless, and harmless method. ECG machine records the electrical impulses coming from your body. It does not put any electricity into your body. What happens when your heart produces tiny electrical impulses which spreads through your heart, and finally it makes your heart muscle contract. So with this each contraction we can see waves on your ECG graph paper. And then how is it done? So who can do it for you as well? So a cardiac technician.
Next slide.
Sorry.
It's okay.
Cardiac technician, cardiovascular technologist, nurse practitioner, as well as laboratory technician can do it for you. When you go to have your ECG done, the technician will ask you to either lift up your shirt as well as remove your shirt. So this
It's a little to the right. We can't see you.
okay. Sorry. So they may ask you to lift up your shirt or remove your shirt so they can apply some stickers around your chest. Once you're ready, they may, if needed, they may shave some hair from the chest or clean the skin with the alcohol just to get the clear ECG from your heart. Then they will have you rest on the bed and will apply about 10 electrodes directly on your skin. They may feel cold to your skin, but it will not hurt you at all. They will put 6 electrodes around your chest area. 2 will go on your both arm, 2 will go on your both legs as well. So specific placement for each electrodes are necessary to see the different segment of your heart. And then wires from your electrodes are connected to the ECG machine, and the machine will finally detect and amplifies the electrical impulses and records on ECG paper. Then they will ask you to not to move for a few minutes only. Once they see the clear ECG on their screen, they will print out the ECG and send it to your doctor for interpretation. After the procedure, the electrodes are removed and discarded as well. It takes about 5 minutes to do the ECG. So this picture will help you to understand the placement of the electrodes, which is on the chest lead as well as limb lead. Some of the indications of having your ECG done. Okay. There are many indications where your doctor would ask you to go for an ECG, but listed here are the most common ones. So if you ever complain to your doctor that you're feeling shortness of breath, palpitation, lightheaded or dizziness, chest pain, sometimes it is also done as a part of routine tests. So if you're going for any operation or any procedure done, they'll ask you to go and have your ECG done. And sometimes also to see the effect of the medication. So if some of you are on medication, like beta blocker, they want to see if the beta blocker is working on your heart rate properly or not. Moving forward, what can be seen by your ECG? Because an ECG can help find abnormal heart rhythms, your doctor may see that your heart is going too fast, going too slow, or sometimes irregular heart rhythm can be seen also. Or heart attack, which may happen recently or some time ago, can be seen by ECG also. What happens when you suffer from a heart attack? It causes damage to your heart muscle and it heals with the scar tissues, and this can be detected by abnormal ECG as an abnormal ECG pattern. They also can see normal pacemaker function by an ECG. And last but not least, an ECG can pick up all kinds of electrical conduction abnormalities. Say, for example, left bundle branch block or right bundle branch block as well. And at the very end, the good thing is ECG has no contraindications, but there are some limitations for this test, which is sometimes it can definitely diagnose a heart problem. However, normal ECG does not rule out any serious heart disease. Sometimes, say for example, you may have an irregular heart rhythm that you are going in and out of it, and recording can be normal between that episodes. Also, not all heart attacks can be detected by an ECG. An angina, a common disorder, cannot usually be detected by routine ECG as well. Thank you once again. Thank you very much for listening.
Great. Excellent, Shital. Thank you very much. Okay, good. So ECGs, great way to get a good feel of how the electrical system of your heart works. It's the gold standard without a doubt. But as Shital just mentioned, I think on our last 1 or 2 slides, I mean, it takes a couple minutes to do an ECG, right? Your heart beats 100,000 times a day. So what if you have an abnormality in your electrical system, a so-called arrhythmia, but it happens when you're not at the doctor's office hooked up to a cardiogram? And quite truthfully, that happens all the time. You guys know that, right? I mean, you're feeling kind of weird. You go see the doctor and you're not feeling weird. You leave the doctor and then you start feeling weird again. It happens to all of us. So what kind of tests can we do that might be able to cover that? Well, there is a type of test that we can look for more electrical problems over a longer period of time. And for that, we're going to listen to Stacey.
Thank you for almost not introducing me. All right, hi everyone. So a Holter monitor, as Rob just said, is used to diagnose irregular heart rhythms just by attaching some electrodes to your chest, which are attached to that small device, the size of a credit card almost now. Okay, so you may have also heard of this referred to as ambulatory monitoring. It's a non-invasive tool. You can wear them for 24, 48, or 72 hours, unless of course you've been given a loop monitor that you might have for 2 weeks to a month, but that's kind of different. So it's uninterrupted recording of your heart over that time period, which allows you to catch those things that you might not catch when you're at the doctor's office. So brief history on the Holter monitor. That guy on the bike there, the big thing on his back was the original Holter monitor. It weighed about 85 pounds, and he had to pedal that bike to generate the power for it. So that being said, that was not used on cardiac patients. It was put into clinical use in the early 1960s when it was made much smaller by microprocessor technology. So the modern device in the picture there is what you would be receiving now. It uses digital technology, so it's similar to your digital camera. the information is recorded on a disk and uploaded onto your computer. In a matter of minutes, the software can determine the different types of beats. It'll give you an average heart rate, minimum heart rate, maximum heart rate, and then anything it doesn't understand is what's reviewed by a technologist. So before any of that, when you're having the Holter monitor put on, anyone who's had one probably hated it. So we're not just trying to beat you up. There's a reason for everything we do. So the skin has to be prepped, rubbed with alcohol, scraped or abraded, so that stuff that feels like sandpaper, that's not for fun. It just gives us better skin contact. Anyone with a hairy chest, you do have to be shaved or those electrodes aren't going to be staying on for 72 hours. And all the tape we put on is just to prevent any tugging on the wires. We want the cleanest image possible. Otherwise, guess what? You'll be coming back again because the reading showed nothing. And then the small device is just put on a belt or on a strap around your neck, depending on what's more comfortable for you. So when you're wearing the monitor, we want you to do your normal daily activities. Don't go home and sit on the couch because chances are that's not going to bring on any event you're normally having. Aside from taking a bath or showering, because the wires can't get wet, obviously. And then avoiding any contact sports, if you were planning to play any, or if you're going to work, you have a job like welding, then that's probably not a good idea. There are no real hazards other than you may feel uncomfortable, itchy, your skin may go red. If you are itchy and red, then maybe go see your pharmacologist. They'll probably give you some Benadryl for that. Patient diaries, you're usually given one of these to go along with your Holter monitor. It's kind of annoying keeping track of everything you do, but this allows us to relate any event you might have had to what we see on the images afterwards. Or if you say you went for a jog and there's something irregular on the image, we'll be able to relate that. So as I said before, the analyzing software, it groups together similar rhythms. So the picture on the bottom there, the blue screen, is one type of software and what we would see afterwards. So the technician will review it, come up with a final report, which is reviewed by your physician, who will then let you know what the final result is. So why would you receive a Holter monitor? If you're having any of those symptoms, so palpitations, you might be feeling a fluttering in your chest, missed beats, skip beats, extra beats. If you've had a fainting episode, if you're experiencing chest pain, nothing's been found on an ECG. If you're having regular shortness of breath, any arrhythmia or abnormal heart rate, or any type of fast heart rate, so anyone living with atrial fibrillation, you might be given a Holter monitor pretty regularly. Or you may not be symptomatic, but there's been something abnormal found on your ECG. You might have a irregular pulse. You might have some swelling or just irregular skin color. So it could also be used as a surgical follow-up. If you're having silent ischemia, so that's when you do have blockages in your heart, but you aren't aware of them with any symptoms. There's no chest pain, there's no shortness of breath, any type of cardiomyopathy, or after you've had a heart attack, your doctor may request a Holter monitor just to see how things are going. And then you might think there's no reason to have it, but your doctor could just be checking to see if any of the medications you're on are working properly. If you have a pacemaker, it can check if your pacemaker is functioning properly throughout the day. And if you have sleep apnea, well, you're probably going to have all of these tests. Okay.
Very cool. Thank you very much, Stacey. Okay, so the Holter monitor is also kind of cool, and it's something for you guys to keep in mind. If you're ever having symptoms and you go to the doctor sends you for a test, ECG, and while you're having the ECG, you feel great. You really want to be monitored while you have the symptom. Okay, that's very important. So it's good to know that things like Holter monitors exist. Also, Stacey mentioned something called a loop monitor. A loop monitor is like a Holter, but you end up wearing it for 2 weeks, and it only records when you tell it to record. So it's just there, and then if all of a sudden you get the symptom, then you get once a week, you end up pushing that button, and then it'll go back in time about a minute and record what your cardiogram looks like for a 2-minute block. Right? So that's another good thing to be aware of as well. Okay, so We've talked about the valves. We've talked about the electrical system. Let's talk about the pumping system of the heart. The pumping system, the muscle, is called the myocardium. As I said, it's stimulated electrically 100,000 times a day. I can't even, how many is that, 2 trillion? Almost 3 trillion times in a lifetime. All right, so it's stimulated an awful lot. Size-wise, it's about the same weight as a good-sized steak. All right, 8 to 9 ounces. Guys are a little bit bigger. Pushes out about 70 mils per heartbeat, which works out to over 2,000 gallons a day. All right, so the heart is one of the hardest working muscles in your body by far. For it to work properly, it needs a constant supply of oxygen-rich blood. It gets this blood from the outside. Everyone thinks, well, there's blood in the heart. That's where it gets its blood. That's not the case. The heart muscle gets its blood from arteries just like every other part of your body. It gets its blood from the coronary arteries. The coronary arteries originate right off the aorta. Right? So the left ventricle, which is that pumping chamber of the heart, as it contracts, it squeezes blood out through the aorta. The first blood vessels on the aorta are your cardiac arteries. Blood will go into those coronary arteries, and it'll supply the heart muscle with oxygen-rich blood. Give me 1 second. 1 second, Marissa. So if we want to find out if the heart muscle is working properly, we really want to make sure that it's getting all the oxygen-rich blood that it needs, because if it doesn't, the electrical system can start getting messed up. The pumping system itself won't function as effectively. So it's very important. It's critical that your heart muscle get all this oxygen-rich blood. And how can we do that? A number of ways. So Marissa is going to talk to us very briefly about cardiac stress testing.
Good evening, everyone. So just looking at the picture on the right, you guys are all the wolf, and we are definitely the pigs. I'm sure you all felt like that at some point. All right, so before we had these lovely treadmills that you were huffing and puffing on, the test that we used to run was called the Master's two-step exercise test. So we take your heart rate, your blood pressure, your ECG before you do the test, and then we would have you do 90 seconds of stepping. Okay, so it's kind of like a really fast aerobic class. And then you would, once you were done, we would rush and try and do another ECG, heart rate, and blood pressure. So this would hopefully bring on patients' symptoms of angina. Then we got technologically savvy and created treadmills. So kind of a big jump from stepping to running or walking fast on a treadmill. So what happens on a stress test? Most of you are familiar with this. We prep your skin. So we rub with alcohol. We use that fun scratchy tape and get all the oils off your skin. We take a resting blood pressure and electrocardiogram. And then we have you walk on the treadmill or pedal the bike for an extended period of time. Okay? And then throughout the test, we monitor your heart rhythm, your blood pressure, and your ECG. So the stress test can be performed for a variety of reasons. We want to confirm the diagnosis of coronary artery disease, figure out, is the pain that you're having, is it cardiac or is it muscle? We want to assess, is your heart rhythm coming on with exercise or does it come on at rest? And we want to be able to detect any abnormal blood pressures that we may not see if you were just walking around day to day or at rest. So is your blood pressure skyrocketing when you exert yourself? Okay, so what do we look for in a stress test? So we want to see if there are electrocardiogram changes that could suggest lack of blood flow through the coronary arteries. We want to see, is there a new onset of arrhythmia? Are you walking on that stress test and do you go into atrial fibrillation? Do you have extra heartbeats? Is it being brought on by your walking and does it go away with rest? We want to know, are you getting symptoms of angina and at what effort level do you get those symptoms? And then we also want to see what your response to blood pressure is. So does your blood pressure drop when you do when you exert, or does it go through the roof? Okay. So we also do it for evaluation purposes. So this is the test that all of you do when you come into this program. And this lovely picture at the bottom here, that's me doing the functional stress test. So I found out that I was really out of shape. I'm in much better shape now than I was during that picture there. But when we say that we know how you feel with that lovely mouthpiece, we really do, okay? So we want to see, are the medications you're taking working properly? So are the beta blockers keeping your heart rate low enough to be in a safe range for you, okay? We want to know, how is your heart after you've had the heart attack? With the damage that may or may not have been done to your heart, what is your functional capacity? How much effort can you give before you don't feel well? And then we want to get the response of, is our program working for you, as long as you're keeping up to your exercise? So, you know, walking the 5 days a week at the prescribed rate. Do we need to change your exercise program? And are you getting fitter and stronger? Otherwise, we need to change what's going on or what's happening with you. So all of you got to, well, most of you had the opportunity to go through our program. And we assessed you, usually for most of you 3 times. So at the beginning, the middle, and at the end. And then hopefully most of you come back on a yearly basis and get tortured from us once in a while. So how long does a stress test take? Generally anywhere from 3 to 9 minutes is what we see on average. There are people that go much longer than that. There are people that go less than that, and that's totally fine. We have different walking protocols, which is speed versus the incline. So for some of you, we keep it nice and flat, and we just increase the speed as you go. For some, we increase the speed every 3 minutes and the incline every 3 minutes. And that one is the most common. It's called the Bruce protocol. So this Bruce guy was pretty intelligent and is well known because this protocol is used all over the world. So generally for diagnostic purposes, meaning can we significantly say that you may have blockages in your arteries, we need to get your heart rate to 85% of your predicted max. So what that means is we take 220, we minus your age, and then we multiply by 85%. And that number, we want to get your heart rate at least to that number during a diagnostic stress test, okay? And that can tell us, yep, you know, are you getting these changes with your heart rate that high? Okay, well, maybe there's something going on. We should send you for further testing. If we don't get you to that 85%, it's iffy if we can confidently say whether there's something going on or not. So we may need to do another type of stress test or other investigations to see. So next I'll talk about stress echo. So Rob had talked about the echo part before, so now we're just going to combine the two. So generally this is done just so that we can get more information out of your heart muscle, okay? So patients are prepped just like a normal stress test. We have you walk on the treadmill until we get to that peak heart rate. So as soon as you said, you know what, I've had enough, I need to stop, we hit that red stop button that we never ask you to, we never let you touch because that's us, that we touch that. And then we have you lie down really quickly to get your to get your exercise echo pictures. So we do pictures before for the echocardiogram. We have you walk on the treadmill, and then we stop it and get your pictures of your heart muscle while it's beating really fast. So the most important part is that we get you lying down and we get those pictures within the first minute or 2. Anything beyond that, your heart rate starts to slow down and we may not get as accurate of pictures. So here are some images, just for as an example. So it's fancy cutting the heart in a couple spots. Let me just show you a picture here. Let's see here. All right. So I'm just going to show you, this is what we're kind of seeing when we look at an echo. So we all know the left ventricle here. So, all right, so these are pointing, so it takes a while to get used to looking at an echo. Sometimes it's like, man, what am I looking at? I have no idea. It just looks like a bunch of arrows pointing to black spots. Let me go a little faster. So this is what we see. So you notice you see the valves there opening and closing, and we're looking at the muscle contracting, okay? So we want to see, is the muscle working properly? If you've had a heart attack and it has damaged part of the muscle, how much damage is there, and is it affecting the blood flow at all? So those are all the lovely pieces. All right, and that'll be it for that. Okay, so why do we use a stress echo? So we want to detect ischemia. All right, so what ischemia means is there a lack of blood flow or oxygenated blood through exercise? So it gives equal information to a regular stress test, but plus we get the muscle and the structure pictures, all right? So we're able to see the structural damage, if there has been any. Is the blood flow going properly through the heart? Has your heart enlarged from high blood pressure or from your heart attack? And we want to see if there's any valve problems. So a stress echo is considered a positive test for ischemia if the echo shows wall motion abnormalities. So what that means is when the ventricle goes to squeeze, for example, it's not squeezing in sync. So it kind of looks like it's a bit wobbly. It just looks like it's just not doing a proper squeeze. All right. And then stress testing is a very efficient way to see the flow of heart functions. Okay?
Yes, thank you, Marissa. So excellent, excellent, and there we go. We said we were taking a look and wanting to see how the heart muscle functions, and if the heart muscle doesn't get all that oxygen-rich blood, that's where the stress echo, as Marissa said, really comes up. If the heart muscle's not getting all the oxygen-rich blood, it doesn't function properly, doesn't pump properly, it doesn't move, and that's really what we're looking for. And another thing that's interesting, we get this all the time. Rob, you know, my cardiologist wants me to go for a stress test. Can't I just do it here? Remember, for a stress test to be diagnostic, you need to get your heart rate up to that 85% of age predicted heart rates. What we do now, sometimes we'll get you guys up to those levels, but our testing here at the center is not designed to be a diagnostic test. Our testing is a fitness test, right? So we are doing it for a different reason, and a lot of people always get caught up with that. So stress testing is great, and all the testing that we've done, or the procedures or investigations that we've looked at so far, they're all fairly low risk, and they're nice and easy, they work really well. But there's multiple ways to look at different problems. So we talked a little bit with Marissa about stress testing to see how the heart moves. That's not the only way to see how the heart muscle itself is working as well. You can do, as I've got this lovely nuclear image up here, a bunch of different nuclear type procedures, which also give your cardiologist a lot of information. So with that thought in mind, we are going to listen to Cindy, right? Cindy, come on up and she'll talk to us about nuclear options.
So the nuclear medicine test that I'll talk about is equilibrium radionuclide ventriculography. Fancy name, but it's also known as a MUGA scan, also full name as multi-gated acquisition scan. So what is it? It's a nuclear medicine test designed to assess your heart's wall motion abnormalities, cardiac chamber size and morphology, and ventricular systolic and diastolic function. In particular, left and right ventricular ejection fractions. So ejection fraction is a measurement in percentage that measures how well your heart is actually pumping. So the average number for that would be 55 to 70%. So why is it done? So it's done to evaluate how well your heart is pumping, and particularly for cancer patients, this test is done to track if the chemotherapy is actually affecting and damaging your heart. So a lot of times these tests are done on these cancer patients to see if it's safe for them to continue with their treatments. So what happens during a MUGA scan? So they'll connect ECG recording throughout. They'll connect an IV line to inject the radioactive tracer, and that's what's picked up by your body and is taken by the gamma camera that takes pictures at specific times during your heartbeat. So the test may be done at rest, exercise, or both. If it is done during exercise, the bed that you're lying on, at the very end there's actually pedals, and then you actually pedal on while you're lying down on this machine that takes the pictures. So how long does it take? It takes generally about 1 to 2 hours. So what do you see? So the technologist will see a screen that looks like this behind their computer, and the computer will take these pictures, and then the computer puts them together, and then that is sent to the doctor. So what are the risks? So there may be some allergic reactions to the radioactive substance. However, it is safe for most people. Your body will generally get rid of the material within 24 hours. There may be some bleeding or soreness from the injection site, especially if you're on any blood thinners. You might just have to hold on to that site for a while just to prevent further bleeding, and just to avoid if you're pregnant. So what happens afterwards? Generally, you can go back to your normal activities right away. Just drink plenty of water to flush the radioactive material out of your body. Your doctor will receive the results, and then your doctor will discuss the results with you with that.
Thank you very much, Cindy. With our nuclear option. Great. Okay, so I've got this lovely slide of our home here, the Milky Way galaxy. And I put this up here because everything that we've taken a look at is really taking a look at a large level of the different parts of our hearts, right? Where, you know, the last couple of investigations have been talking about wall motion, how the heart works, and everything like that. Now, if your heart's being starved of oxygen-rich blood, it's not going to work as well. It's not going to move as well. So what's the next step? Right? Well, the next step is, okay, if it's being starved of oxygen-rich blood, that means there's probably a blockage in one of your blood vessels somewhere. So the motion stuff is taking a look at the big picture. What we want to do is we want to kind of narrow it down and really drill down and see, okay, what's causing this problem? So next procedure that you might end up getting sent in for, and this is a very, very particular test to take a look at blood flow blockages, is of course an angiogram, which many of you are very, very familiar with, and Jen knows all about. Thank you, Jen.
Hello, everybody. Can you guys hear me okay? All right. No? It's like, oh dear. All right. So I'm going to be talking about the angiogram with you folks. Basically, who here has had one? Yeah, quite a few of you have had one. Basically, we're looking at the coronary arteries of the heart, and why do we need one? Why did the doctor send you guys for one? It's mainly because of all the symptoms that all of the other colleagues of mine have mentioned about. So things like chest pain is a very common one, and they've done all these tests, and they can't figure out what's going on. So as Rob mentioned, we want to get a little more specific. Some people called this maybe like the gold standard, but it comes at a risk, which I'll talk about shortly. We are looking at the coronary arteries itself. We're checking the flow. We're checking if there's anything blocking it, or if there's any narrowing of the arteries, or that would be the atherosclerosis, and if there's any pooling, and we relate that back to the valves. So what is an angiogram? I don't know if you guys remember this traumatizing event, those of you who've had it, but most people do not forget this test. Short story is basically we're taking an x-ray of the coronary arteries. But just like any muscles, if we were to take an x-ray, we can't actually see what's actually going on in that individual muscle. So we have to highlight that coronary artery and then take the x-ray that way, and so we can see the full picture. Check if there are any blockages or any narrowing, and then we decide what we're going to do from there. A catheter, or so a long piece of plastic, it is inserted into your body, and we release some dye through that catheter, and so that kind of highlights what your coronary arteries look like, and then we take x-rays, or that's what the pictures show, and that's what the doctors look at, and then give you guys your evaluation of what's going on with your heart. So this is an example of how the room could be set up. So those of you guys are lying on the table, so you might not remember or see most of this stuff. Lots of screens going on. The doctor's taking a look here, for example, at 2 screens that are taking x-rays throughout your test and procedure. If you take a look closer, where's the mouse? Oh. if you take a look closer down here, they are actually inserting the catheter at that point and actually fishing through. So they can't actually see anything, but they rely on the x-rays, threading it through your heart, and then injecting the dye and then seeing any blockages if there are any there. Time sensitivity with the angiogram. Some of you guys have said that you guys have had staged angiograms. So that might be because you've had too much exposure to the x-ray or to the dye. So there's some risks with that, and then they keep everybody in the safe guidelines, and so they might have to do the procedure or the intervention another day. So this is just the angiogram, just to check what your arteries look like. Does that make sense? Okay, some nods. And then, I have a good slide on that. We're going to get there. So for us, so there are some techs in there with the doctor. So we're either standing right by the doctor to help with which wires to hand them, or there's some people standing behind the screen so that they don't get x-rays, and they check your heart rates. They just make sure your ECG is going okay. They check your breathing, and just making sure you're stable, because it is a very invasive procedure. So all the tests that have been talked about before, we don't actually go into the body except if you count swallowing that transducer for the transesophageal ultrasound. So here we're breaking the barrier. We need to prep you and make sure everything's ready. We have to sedate, give you a sedation, maybe for some nerves, make sure that there's no nausea. Doctor doesn't want you to throw up on them, and nothing to eat before. And we're gonna, as I mentioned, we record things like your like the fluoro time, so that's how much radioactive exposure that you have, the medications that you're given, and then the supplies used. And so these are what the wires look like. Oops, sorry. These are what the wires look like. And so as we mentioned, kindly in the audience there, so we go through places like the femoral, the brachial, the radial, the axillary, the jugular, subclavian, and so the next picture, oh, this is a technique. If you guys want to try that, don't try this. But it shows you that it is quite like they have to poke through, they have to take it back out, they have to put it back in and insert the correct wire and go through. So they went to school for it, yeah. But this is a nice slide here that it shows where our insertion points are. So if you go back maybe about 20, 30 years, the doctors who've done their schooling at that time, they're actually more familiar with the femoral, so that's down by your groin area. Okay, and then the doctors that are more coming into currently this time that's graduating and finishing their school, they actually prefer the radial, so that's through the wrist down there. Yeah, so some of you guys have had wrists done, right? Some of you guys have had your femorals. The not as common ones that we would use we would go through the thank you, the jugular on this side, or we have to go through the subclavian, so underneath your clavicle, or we go through the brachial on this side, just because sometimes the wrists, like they're smaller vessels, they may collapse, so they might have to take that one out and go through other areas. And then the femoral, I call them the classic doctors, they like to go through that one because they know it's a nice big artery, they know it's a surefire, and then that's the one that they go through. So now this is what they see as an angiography. You get your basically three main arteries. So you have your right side on this side here, okay? Then you have your left side, and it breaks off to the circumflex or the left anterior descending. This one's also known as the widowmaker as well, okay? So these are the four main areas that they do look at, and then there's all these tiny little arteries that branch off, and so they're smaller, so they're going to be definitely harder to get to, and so that's why sometimes the doctors may say to you, we didn't get to everywhere, we're just going to leave certain spots, but they do definitely look at these four main areas. Okay, this is what it looks like. So they're inserting, so they have the lead wire already done, inserted in, And then what they do is they inject the dye, so you can see that it's flowing through. And so they are taking time clips of the images, and you can see where how your coronary arteries actually go through your heart. So it's like the pictures that they actually draw in your textbooks. It's real. Now, you might get this image. Some of you guys, get this image that we always ask for. Did they give you a picture? This one's a very crude drawing, but then they let you know, like, okay, so this part, off the right coronary artery, there was 100% blockage of this person. This one, they had the intervention. It's a stent. And then down here, they might not have been able to get to it because it's too small. It's too small to put either a stent or to do a balloon plasty in it. Okay, so what do we do with this information? So what did you guys have done? Some of you guys got a balloon angioplasty, just a straight angioplasty, or an atherectomy. And so pictures, they speak 1,000 words. So this one here, this artery, shows that there's some blockage going on. So they feed the guide wire through, okay? And then they switch out the wires, and then they're going to put this balloon in, and then they're going to inflate it. So varying times of how long they inflate it for and how many times will depend on the severity and what the doctor feels appropriate for that situation. And the hope is then it pushes the plaque and everything out to the walls and it stays there. And then they withdraw everything and there's flow. Okay, that's the hope. But a lot of people go for an actual stent. So it's a scaffolding, so I'll show you a bigger picture here. So a scaffolding, so they put it in, so it's the same thing, they have it collapsed, they put it in, and then they open it, and hopefully it sticks, it opens up your arteries, and this is what we would like to see. Unfortunately, not very much, but a few small percentage, they do get some restenosis, and so the plaque comes back. And so we might have to open it again, or we might have to go to something more invasive like bypass. Okay. So you can see this one's kind of cool. No flow, intervention, flow. So it's not the exact same image only because the heart has moved. So we can't get exactly that you're seeing the three branches exactly in this manner. That's the only reason why, if you're being picky on me here. Okay. So post-care, you're usually not admitted. Basically, we just make sure that we put pressure onto the wound site, and we just make sure that there are no complications. You still don't have chest pain. You're feeling fine. Your blood pressure comes back to normal. Heart rate comes back to normal. And within 24 hours, the hospitals do discharge you. I'm sure those of you who've had it remembers that. And then we go from there. Okay.
Cool. Thank you. Excellent. So now we know all about angiograms. Now you can imagine it's a very invasive procedure. And when you take a look at all the things that we've done, that one probably carries the most risk, right? The other ones, you might have an allergic reaction to some tape. You might get a bit of a cut when you're having the hair shaved off your chest. But threading a wire up into your coronary arteries is probably the most invasive test that we talk about. So a lot of people are now wondering, it's like 2016, is there not a better way? Can we not find out what the arteries look like inside without actually having to go inside? And as it turns out, there is technology that will do that. That's getting better and better. And that's what we're going to hear about next from Marcella. Thank you, Marcella.
Thank you. Hello, can everybody hear me? Yes? Lower? Lower? Okay, great. So just out of interest, has anybody here had a CT angiogram done? Anybody? No? Okay. One? All right. Okay, so we got about 5 minutes and we're going to discuss some history. We're going to talk about the indications for a CT angiogram. We're going to talk about the procedure, and we're going to conclude with a short video. Okay? So the CT scan was invented in 1972 by a British engineer named Godfrey Hounsfield and a South African-born physicist, Alan Cormack. The CT scan was first used for brain imaging, and not until the 1990s did it begin to be used to scan the heart and the arteries. So with advances in technology over the past 10 years, the cardiac CT angiogram has grown in popularity. It's reliable, it's less invasive than the angiogram, it can be done quickly, it's relatively inexpensive and can be used to investigate low to moderate risk patients while leaving angiograms open for high-risk patients and emergency cases. Cormack and Hounsfield were awarded the Nobel Peace Prize for their contributions to medicine and science. So CT scan or CAT scan stands for computerized tomography or computed axial tomography. Tomography is from the Greek word tomos, meaning slice or section, and graphia, meaning describing. A CT angiogram is a test that uses an X-ray to provide detailed pictures of the heart and blood vessels that go to the heart. During a CT angiogram, a special dye is put into the vein in your arm or your hand to make the blood vessels easier to see on the scan. A large donut-shaped X-ray machine or scanner takes X-ray images at many different angles around the heart, and these images are processed by a computer to produce slices or cross-sectional pictures of the heart, which is recorded on a film. This is an example of what a CT angiogram picture would look like. Okay. So the most common reasons to order a CT angiogram are to assess individuals with atypical symptoms for heart disease, such as chest pain, shortness of breath, unrelated to physical exertion. It's to evaluate symptomatic high-risk patients with normal stress tests who are not candidates for an angiogram, to further evaluate inconclusive stress test results, and to evaluate cardiac bypass grafts or stents for blockages. A cardiac CT angiogram can identify a narrowing or blockage in the coronary arteries, heart problems such as pericarditis, which is a buildup of fluid around the heart, damage or injury to the heart valves, a bulge or tear in the aorta, which is a large blood vessel that carries blood from the heart to the rest of the body, a blood clot in the lungs, and an abnormal pattern of blood vessels that may be a sign of a tumor. So to prepare for the CT angiogram study, you should not eat for about 4 hours prior to your scheduled appointment, and you should not exercise the day of the study. During the CT angiogram, you'll be asked to lie very still on a table that's attached to a CT scanner. A special contrast dye is injected into the vein, again into your arm or your hand, and you may be given a medicine called a beta blocker to slow down your heart rate during the test. The slower your heart rate, the better the pictures, and they actually try to take the pictures in between heartbeats. The table will slide into the round opening of the scanner, and it will move slightly while the scanner takes pictures. The technologist may ask you to hold your breath for a few seconds, again to take better pictures. And the CT angiogram usually only takes about 10 to 15 minutes. It's not painful. When the dye is given, you may feel a brief sting or a pinch from the needle. You may feel warm, flushed. Some have an upset stomach, headache, or a metallic taste in their mouth. And the risks from having a CT angiogram are small, but the risks include exposure to radiation, so you want to make sure that this test is needed, an allergic reaction to the contrast dye, and for individuals who have kidney problems, the dye used during the scan can cause kidney damage. CT angiogram is usually done by a radiology technologist, and the pictures are read by a radiologist. And the results are usually ready for your doctor to see in about 1 or 2 days. Okay. So next I'm going to show you a quick video, and this video was put out by the British Heart Foundation, and it follows a patient through a CT angiogram.
This film will show you what to expect if you are having a CT angiogram.
I'm Betty and I live near Oxford. I'm having a CT angiogram today. Well, I'm not really frightened of the procedure, but I'm just hoping they're going to be able to track down the problem.
My name's Chirag Shivadarya and I'm an honorary consultant cardiologist at the John Radcliffe Hospital in Oxford. A CT angiogram is a relatively new way and a new technique that allows us to look at the coronary arteries. The conventional way that we assess a patient for coronary heart disease is with a diagnostic angiogram that's more invasive for the patient. A CT scan is a special form of X-ray that involves radiation, and it enables us to take pictures of the coronary arteries. And from those pictures, we can work out whether or not the patient has narrowings in the coronary arteries that may be causing their symptoms and may be important to their health. This is an outpatient test. When the scan itself is taking place, intravenous contrast is administered through the cannula in the arm. The patient may experience a hot flushing sensation. Patients sometimes describe the feeling that they feel like they're wetting themselves. That's not what's happening. It's a completely normal reaction to the contrast, and again, it wears off very quickly. There are a couple of key steps for the CT coronary angiogram. The first thing is that the patient's heart rate needs to be well controlled with a medication like a beta blocker. And the second thing is they need to hold their breath, taking the same size breath each time they receive the instruction.
Breathe out. Hold your breath.
The scan itself takes about 10 to 15 minutes. It's a routine, very safe and harmless procedure that we perform many times a day, and from a patient perspective, it's a much more pleasurable experience than having a more invasive coronary angiogram.
I didn't realise when the dye actually went in, but I did have a sensation of a hot flush, but that very quickly passed. Well, everybody explained very well what was going to happen and told me what to do, and it was absolutely fine. Nothing to worry about at all.